Yes, please. So thank you for waiting. Yes, here. Okay, Dr. Cindy, if you're ready, I'm starting the timer. Yes, started the timer, and here is your question. Right, if you have read and understood, kindly begin your examination station.
I'll wash my hands.
Yes,
I will introduce myself and I
yes,
will check for the patient's name and the age. Then
yes,
I will take consent and
yes,
I will explain the procedure. Then I will also position the patient. The patient will be sitting down and I'll be placing a pillow under the patient's hand. So
yes,
I'll ask the patient to rest the pillow. I'll ask the patient to expose the upper limb up to more above the elbow.
yes,
So then I'll ask the patient whether the patient is in pain. Then I
yes,
will start by just inspection to check for any deformity, any obvious deformity of the hand. Then I will also check for any skin changes, any presence of scar that might denote
yes.
previous surgery. Then after that, then I will proceed to palpation, so which I will palpate for
Both
both
hands.
finger, yeah, of course, both hands. So, and I will always start the examination from the good side, then move to
Yes,
the
good,
side that having
good.
a symptom. Then I will feel the pulse. Then I will feel the temperature of both hands. Then I will feel all the
Yes,
joints to check for any form of nodules. So up to
yes,
the elbow joint. Then I will have to feel the bony prominence from
yes,
the joint to
yes,
all the carpals, metacarpals, and the interphalangeal joints or carpal metacarpal joints, all the joints. I have to feel everything one by one using
yes,
my two hands. So after feeling the joint, then I will now proceed to movement. First, I will ask the patient to do an OK sign. Then I will ask the patient also to move the thumb, both flexion, extension. That by telling the patient to raise the thumb while laying the palm flat, facing up. Then I will ask the patient to raise the thumb up. Then flexion, extension, or position to check for all the movement of the thumb. Then after that, I will ask the patient to make a star shape of hand. That's to abduct the fingers. Then adduct the fingers for both hands. Then after that, I will repeat the movement. I will check for restriction of movement to check for power. Then for flexion and extension of the wrist. Then for the thumb. Then for adduction and power of the fingers. That's to check for the interosseous, whether palmar or distal interosseous. Then after that, then I will check for power grip. They ask the patient to pick a pin or button to check for pincer grip. Then after that, after doing that, then I will now proceed to check for integrity of the flexor deuterium profundus. So by
yes,
the patient by fixing all the finger, then allowing the distal part, distal and interphalangeal joint to move. Then I will check for integrity of flexor deuterium superficialis. Then that's the proximal interphalangeal joint to move for each
yes,
finger. Then after that, I will now proceed to special tests like talent test. So by telling the patient to make a prayer sign or inverse prayer sign. So check ask the patient to stay in that position for a couple of seconds. If there's any kind of tingling sensation or pain along the distribution of medial nerve, then that will be positive. Then I also ask the patient to do next sign whereby I tap along the
How would you
above the
make, how would
carpal
you, yes, how would you check for Tinel sign?
by tapping along the over the carpal tunnel. So if there's any
Yes.
single sensation or pain along the distribution of the medial nerve sign, then after that, I will perform, if time permits, I will perform an Allen test. So check for integrity of ulnar and radial artery supplied to the finger. Then I will now do check for sensation, both using the cotton wool and the needle tip. So to check all distribution of the both radial, ulnar, and the medial nerve. So radial nerve will be at the dorsal part of the hand,
Yes.
just along the first web space. Then for the medial nerve will be either tip of the index finger, and for ulnar nerve at the tip of the little finger.
Yes.
So then I will check for both pain and the sensation for both hands, starting with the normal one. Then yeah. So after that, I will then thank my patient. Then, okay, before I thank my patient, then I will also give the patient a sheet of paper to hold. I'll ask the patient
Yes.
to hold the sheet of paper.
So
And then I will try
pensagrip.
to remove the remove the sheet of paper to check whether the patient is going to flex the thumb or not. Check for
Yes.
integrity of or whether the patient is going to use the deep corner, which is the adductor pollicis or not. So then after that, I will send the of course I've done the power grip before and the pizza grip. So then I will send the patient, I will wash my hands, then I would like to complete my examination by examining the joint above, which is the elbow joint in details. Then I also like to inspect all the joints of the hand. Then I
Yes.
also like to perform a neurovascular examination of the upper limb. So
Yes.
and summarize my case.
All right. Okay.
So, so
You
today
still,
I have examined the
yes.
55-year-old lady. So with
Brush our
and
Hold on, brush our
pain,
teeth.
pain on
Yes.
the right hand. So on inspection, there's no obvious deformity. The hand seems normal. So on palpation, there's no nodules or no fibrosis or no thickenings or thickenous nodules. Then during movement, I noticed the limitation of movement of thumb of the right hand.
Yes.
Then that's inability to move the thumb for flexion, extension, and the adduction of the thumb. So of the right hand, then sensation of the right hand along the medial nerve distribution was impaired for the right arm, and the Fallen test and Pinette test was positive on the right.
Yes.
So based on my
So
findings,
what, yes, what
my
are your differential
diagnosis
diagnosis?
the carpal tunnel syndrome of the right hand. So
Yes.
I also like to see other potentials such as medial nerve paralysis of the right hand,
Okay.
or
Yes.
yeah, which could possible, or some peripheral neuropathy of the right
Yes.
hand, which could, such as diabetic neuropathy, which
Yes.
can be
Very
excluded
good.
in this person. So
Can you name few risk factors which are associated with carpal tunnel syndrome?
okay, so we have a profession like a typist, but
Yes.
in this case a cleaner. Then we have obesity. We have disease like diabetes mellitus.
Yes.
Then we have a genetic factor. Then female or sex. Then
Yes.
yeah,
Increasing
those are
age.
the of course increased
Yes.
age also.
What investigations would you ask for this patient and how would you treat this condition?
Yeah, so investigation. So I will start by nerve conduction studies.
Yes.
Then I also like to perform ultrasound of the hand to exclude any soft tissue damage or
Yes.
impairment. I also like to rule out any form of fracture that can compress the nerve,
Yes.
so of the wrist. Then yeah, then investigation. I would like to do baseline blood analysis and to specifically exclude the cause like diabetes,
Yes.
high blood pressure, increased triglycerides in the blood.
Yes.
So then treatment, our first start with conservative management, which is include lifestyle modification, loss of weight, control diabetes, and control whatever causes the carpal tunnel.
Yes.
Then I will also prescribe hand splitting overnight for like 3 weeks.
Yes.
Then use of pain medication, starting with a non-steroidal anti-inflammatory medication to control
Yes.
the pain. If that does not work, then I can supplement with the steroid injection. And if all those fails, then we can proceed to surgery to decompress the carpal tunnel.
What surgical option can you offer?
Decompression, surgical decompression.
Okay. Yes.
Thereby we release
Good.
the carpal tunnel.
Yes. Good. Thank you so much. Still, yeah, few seconds left, but then you, 4 seconds left. Good. Thank you. Yes. Any feedback? Did you remember to do pincer test?
Yes, I said on button or pick a pin.
Both. Good. Yes. Good. Good. Yes. Anyone else want to give feedback to Dr. Sunday? Yes, that was good. All right. Anyone else want to go for any station? Someone joined, but then he left. No, he's here. Dr. David, would you want to? Yes. Yes, it was good. And it's always totally random for Dr. Sunday. He doesn't know which station I'm going to give him. So it's always random. That's good.
Sorry,
Yes.
ma'am. I can't tonight, ma'am. Sorry, ma'am.
That's all right. That's okay.
Yes,
I
ma'am.
just wanted to be sure because you joined, so I thought maybe today also. Yesterday you did really well, so I
Thank
thought
you,
maybe,
ma'am.
yeah. I want to encourage you keep on going. Otherwise, yeah.
Oh, thank you very much, ma'am.
That's all right. Yeah, that's okay. No problem. Okay. Maybe if no one else is interested, then we can call it the end.
Ma'am,
Yes. Yes, Dr.
ma'am,
Faria.
assalamu alaikum.
Walaikum salam. Yes.
Ma'am, I want to participate in pathology station.
Pathology
If it is
station.
okay. Yes.
Any?
No, ma'am. Whatever you like,
No,
as I
no.
have requested it.
You tell me. I asked you
Uh,
any pathology station. You
yes.
said no. Any
Yes, ma'am.
pathology.
Any pathology station. Yeah, ma'am.
Okay. Any pathology station. Which one should I bring it on for her? Anyone want to give me any suggestion? Something which we haven't done very recently? Because she has given me full freedom to choose any patho station, so but I don't want her to run away, so okay, I'll give you something which is common, but
Okay, ma'am.
we might have done it before as well, so doesn't matter. Right, so if you're ready, can I start the timer?
Yes, ma'am. Sure.
Okay, good. Starting the timer, and here is your question. Right, if you have read and understood, kindly tell me, considering its surgical pathology station, what is your provisional diagnosis?
My provisional diagnosis will be basal cell carcinoma.
Okay, what are the differential diagnoses that you are going to consider in this
Uh,
scenario?
Okay, squamous cell carcinoma,
Very good. Yes.
actinic keratosis,
Yes.
seborrheic keratosis, tuberculosis.
Yes. Okay. Can you tell me? Yes, please. Can you please
Yes,
tell me
ma'am.
the natural history of basal cell carcinoma?
It is indolent in
Yes.
course with slow progression. It
Very
does not
good.
metastasize in a distant size, but it is locally invasive.
All right. Can you please tell me how would you differentiate basal cell carcinoma from
Basal cell carcinoma occurs in the basal layer of epidermis, whereas the squamous cell carcinoma is occurs in the upper and lower layer of epidermis, and uh, um,
3 to 4 differences you have to tell me?
okay, ma'am.
Okay.
Ma'am, can I skip this
Yes,
question for
and
later?
come back to it later. Okay, please.
Yeah, ma'am.
Can you please tell me how does if basal cell carcinoma metastasizes or not?
Basal cell carcinoma may metastasize to the lymph node. Yes, ma'am.
Locally, you mean locally. Can you tell me
Yes,
what are the 5 major steps when it which occur in all cases of pathological carcinoma cases in metastasis? What are the 5 major steps of metastasis? Doesn't
okay.
have to be for yes.
Okay, it may be direct extension, or it may be extension to the body cavities, lymph nodes, or blood vessel. Then arrest of the capillaries of the secondary side, and then
You have to tell me like in the pathological language, like in invasion and filtration, and then release of neoplastic cells, number 2, and then like this, formation of neovascular, yeah. So
okay, ma'am.
yeah,
Sorry, ma'am. I have not read it in this way.
okay.
This, okay.
Can you please tell me how would you confirm your diagnosis for basal cell
Ma'am.
carcinoma?
Okay. By histopathological examination,
How?
it will be a frozen section biopsy.
Okay. Can you please tell me what should be the ideal treatment for basal cell carcinoma?
It will be surgical. It will be surgical
Yes.
treatment like curettage and electrodesiccation, and
Yes.
then or
And yes.
excision with primary closure,
Yes.
or
How would you do
cryotherapy,
that?
or
How would you do excision with primary closure? Knowing
okay
it
we
that
will
it's carcinoma.
we will excision and will do the frozen section to make sure we have excised the margin of the tissue, and then
That should be how much, considering it can be carcinoma.
we will consider about 4 millimeter
Very good.
around the
Yes.
tumor,
Then yes.
where it is possible, and then we'll do the secondary intention or flaps or grafts,
Okay.
whatever it is
Then
necessary.
you'll also offer cryotherapy. What that is?
Oh,
Can you explain?
if we will do cryotherapy with liquid nitrogen, and
Yes. Very good.
but in that case we will not be able to obtain any tissue biopsy when we
Okay.
use cryotherapy.
What are the other options that you can offer to this patient? One, radiotherapy. Any other options?
Mohs micrography surgery or
Yes.
topical photodynamic therapy.
Very good. And topical
Um,
fluorouracil.
yes, ma'am. Tropical fluoresce, tropical imiquimod 5%.
Okay, very good. Okay, can you tell me that if this patient, you take the biopsy and then comes back, what measures would you do? How would you confirm? Comes back with
Uh,
the lesion and there is a non-healing infection. So what is the most common organism that can occur or can be present?
Staphylococcus aureus.
Very good. Okay. And if the biopsy report comes back with it's positive with MRSA, so what is MRSA?
It is methicillin-resistant Staphylococcus aureus.
How would you manage this infection now?
Okay, if there is abscess, first I will do incision and drainage, and then in outpatient I will give oral antibiotic like
Yes.
clindamycin or amoxicillin or
Yes.
linezolid, and in inpatient I will give vancomycin, linezolid,
Can you
etc. And
please tell me the dose as well and for how long?
for vancomycin I will give doses for 7 to 14 days, but ma'am I can't remember the actual dose of
You'll tell me later. Okay, can you please tell me what are the risk factors associated with basal cell carcinoma?
Okay, risk factors associated with basal cell carcinoma.
Yes.
Sun exposure.
Yes. Good.
Sun exposure and
yes.
I can't remember.
Okay.
Now.
Yes, that was correct. But then you have to remember 3 to 4. One is sun exposed area. All right. But then there should be more as well. Okay. Can you please tell me what is like? Okay. Then that is again in that kind of. All right. Okay. The questions. Can you tell me the pathogenesis of basal cell carcinoma? How does it take place? Because here it says it's purely papule with the central ulcer and rolled in edges. How it occurred?
Madam, it occurs in the deeper layer within the layers of the thick skin and involve the basement membrane.
Yes, but
that's why it is purely papule with centrally placed ulcer and
okay.
inverted rollage.
Okay. What can I ask you? Okay. Tell me, what are the conditions that you should keep in your mind if you are going for a surgical option for a patient with basal cell carcinoma? What are the complications that can occur?
During the surgery of basal cell carcinoma, ma'am?
Yes, or afterwards. You have to keep in your mind.
Okay, I have to keep in mind about the immediate complications of any surgery,
Okay.
like a primary hemorrhage or reactionary hemorrhage that can occur immediately, or injury to the surrounding tissues, and then later it can in late complications it can cause infections, secondary hemorrhage, infection with staphylococcus, wound infection that may be caused by the staphylococcus aureus or other microorganisms.
Okay, if the patient comes back to you and then you have to do the re-excision, what measures would you take to make sure that you excise adequate margins this time?
Ma'am, I will go for the frozen section or Mohs microscopic surgery to ensure that I have taken the.
And then, how would you differentiate your diagnosis? What investigation can you do, which can help you to differentiate differential diagnosis of your condition?
Madam, genetic studies.
FNAC.
FNAC.
Okay, one of the risk factors that I wanted you to consider, because it's carcinoma, it's hypercoagulable state, and then I wanted you to consider that you, depending upon the site of carcinoma, you have to keep DVT in your mind.
Okay. Yes.
And like hematoma, you told me can occur, seroma and thrombophlebitis can occur, but then DVT is also. And if patient happens to develop DVT, then how would you treat the patient? What options would you offer the patient?
To prevent thromboembolism, I can give him to mechanical thromboprophylaxis, like thromboembolic device stocking or pneumatic stock in intermittent pneumatic stocking, mechanical, or I can give him pharmacological advice like taking low molecular heparin or warfarin.
Okay.
To prevent thromboembolism.
You have to give advice for friend. What are you going to keep in your mind?
Warfarin, I have to keep in mind about the INR.
Yes, which should be kept in
2 to 3.
between
2 to 3.
Good. Okay, one last question, then I'll let you go. Can you please tell me the difference between histology and cytology?
Okay, in case of histology, we take the solid sample of tissue with the preserved local connective tissue and the background architecture. But in case of cytology, we only take the sample of tissue without any local connective tissue and without any background architecture. That's why we cannot differentiate between the invasive and the in situ disease by cytology, but we can do it by histology.
Okay, good. Can you tell me, I'm not keeping my promise, Can you please tell me what are the macroscopic features and what are the microscopic features of a malignant lesion?
Okay, in macroscopically, we can find that lesion is rapidly increasing in size. It is fixed with the surrounding structure. It is invaded the lymph node or lymph node or lymph node or nerves. And microscopically, we will found that it has increased cytoplasmic nuclear ratio, increased mitosis, pleomorphism, anaplasia, and loss of polarity, etc.
Can you help me to identify the lesion?
Uh,
In other words, whatever you're telling me, this is like macroscopic feature that you're looking at. So if you can help me describe it. Just
this is
tell me what you're looking at. Yes.
this is, ma'am, malignant melanoma. Like,
No, it's basal cell. Why
ma'am,
there is a
it is
redness?
no ulceration.
Why
I
there
think.
is redness around the? Because I've zoomed it too much to make it
Okay,
bigger. Why there
okay,
is redness around the lesion? What does
ma'am,
this redness
because
signifies?
dilated subepidermal blood vessels.
Yes,
That's why it is
yes,
red.
yes. Good. Thank you.
Thank
Now
you,
I
ma'am.
let you go. Thanks. But make sure you go back, you listen, and then the
Yeah.
questions which you said you'll come back to later, you write down the answers to them and practice them.
Okay.
Okay?
Okay. Okay. Thank you,
Yeah.
ma'am. Ma'am,
Thank you so
which
much. Yes.
book should I use for the few questions that I have not got in the
First
diagnosis
7
syndrome?
chapters of Robin's pathology is good.
Okay.
First
Okay,
7
ma'am.
chapters, I say, of Robin's pathology, because
Okay.
those basic things are only given in Robin's pathology. Just read them
Yes.
quickly, and then you will understand the basics which you need.
Yes.
You know, it's
Okay.
not given in
Okay.
any other traditional notes, but it's given in Robin's basics with pathology. Even PDF is available in the group, unless
Yes. Yes,
you'll
ma'am.
ask me and I'll send you again.
Okay.
So
Okay. Thank you so
just read
much, ma'am.
first 7 chapters and then it will be
Okay.
okay. Yes, thank you so
Okay.
much.
Thank you, ma'am. Thank you
Thank
so
you.
much.
Yes, you need little practice with Patho. Yes.
Yes,
Yes,
ma'am.
good. Yeah. Though it will be only one station for pathology in my exam, but still could be any station. I don't know. They will decide.
Okay, ma'am.
Yeah. Thank you so much. If no one else want to go, then we can call it the end. Yes. All right. Thank you so much.